And so in doing this, we looked back, what was the quality impact of the Reflex biomarker testing for non-small cell lung cancer? We reviewed approximately 600 of our small biopsy cases for non-small cell lung cancer and assessed the impact of 3 workflows. There was a send-out period for molecular testing before we ever existed here. And then when we brought our testing live, there was a period where the testing was now in-house, but it required the clinician to place the order once they picked up that AP report and said, oh yeah, we should be doing molecular on this. Then we implemented the Reflex protocol, and that was sort of the last phase, in-house testing utilizing that Reflex protocol. And we looked at the rate of biomarker-informed testing and care, the rate of test failure by workflow and methodology, initiation time, how long did it take to even get molecular cooking or ordered, if you will, from the time that the morphologic diagnosis was officially made on the biopsy tissue, and then reporting time. So this is some of the data. In this second column here, the send out column, before we were even here, before anyone was, the local champion of molecular testing, raising awareness, molecular testing was only ordered, and this is on the cases where it should have been ordered, right? That qualified for this based on, kind of the standard of care guidelines. It was only ordered 55% of the time. Whereas this moved to 85% of the time when we were in-house and, kind of going around to the different tumor groups and saying, to non-small cell lung cancer meetings, saying, hey guys, we're here, order, there was a local awareness to do this on a regular basis. And then when we moved to the Reflex testing, every single time a case qualifies for this testing, it's getting ordered by the anatomic pathologist. Initiation time, how long did it take to even get the order placed for molecular analysis? It used to be all over the map, right? And that has tightened up significantly if you make your way across this row. And it's basically same day now in terms of the morphologic diagnosis being made, the molecular and PD-L1 testing process is kicked off. What are our quantity not sufficient rates, right? In the send out period, it was 16%. Over, when we looked at these 600 cases or so. When we moved it in-house, it dropped to 5%. There were a couple nuances around of why it sits around 5%. For us, classically, because we watch this, it's more usually around 3% plus or minus. And so there is some rebiopsy, but a lot of times the patients we noted weren't getting another biopsy, right? It was just QNS and let's proceed with therapy. And so the total non-informed care, which is the kicker here, right? It was about 60% during the send out period. And when I mean non-informed care, I mean, you started getting your cancer therapy without having any biomarker analysis being done. When we moved the testing to in-house with the clinical order, it was around 20%, right? They still had to remember to place that order. We couldn't visualize what were the cases that were getting missed from the laboratory perspective. But when we implemented this Reflex protocol, the non-informed care is related to the patients that have quantity not sufficient cases, and they're pretty directly tied. And again, this now, like as we've operationalized this, it really bounces around that 3% plus or minus a little bit. So I think this is pretty significant.